Okay, hi everyone. My name is Inan. I'm an internal medicine resident training in Canada, and today I'll be presenting the vessel of warning, a case of unexplained recurrent arterial thrombosis. So we're talking about a 49-year-old Caucasian patient who was referred for investigation of recurrent renal and splenic infarcts. And we actually investigated this patient for about a year before finding the underlying mechanism. His medical history is significant for metabolic syndrome, prior myocardial infarction, and a small patent foramen ovale. He's also an active smoker. He initially presented with acute left flank and iliac fossa pain, as well as weight loss and hematuria, and an abdominal CT showed 3 bilateral renal infarcts of different ages. He was admitted and further investigated with thoracic and abdominal angio-CT, which showed multi-level atherosclerosis, including of the transverse aorta, but there were no other vascular anomalies that were found. He also had Doppler studies, which did not show any venous thrombosis. At that point, the most likely diagnosis was cardiac embolism, so the patient was started on therapeutic dalteparin and discharged with additional outpatient investigations. Despite therapeutic anticoagulation and even eventually undergoing PFO closure, the patient continued to have 4 other thromboembolic events before being readmitted in our service. And he actually underwent an extensive diagnostic workup in the outpatient setting, allowing us to rule out cardioembolic causes, thrombophilia, hematologic malignancies, as well as myeloproliferative syndromes and rheumatologic disorders. Although he did have atherosclerosis, it wasn't very likely that he would have fat emboli or atherosclerosis emboli, considering that there were no mobile plaques seen on TEE and that the localization of his plaques did not seem to match his infarcts. To be sure that we were exhaustive enough, we referred to a proposed algorithm by May and Moll, which gives us an approach to unexplained arterial thrombosis, and we identified 2 major etiologies that hadn't been fully investigated yet: vasculitis and malignancy. So the patient was readmitted again after experiencing symptoms suggestive of left MCA stroke with corresponding findings on brain MRI. And because he hadn't been fully investigated for vasculitis and malignancy, he eventually had a PET scan, which showed diffuse hypermetabolism of the aortic cross and its proximal branches, compatible with large vessel vasculitis. After excluding infectious and inflammatory causes of aortitis, he was diagnosed with atypical Takayasu-like arthritis based on the fact that he had a younger age and that he had normal temporal artery ultrasound findings. We did recognize, however, that this patient's epidemiological profile was quite unusual for Takayasu. But despite adequate treatment for his vasculitis, he continued to have other thromboembolic events and was even started on infliximab. Despite that, he was readmitted again for recurrence of another renal infarct. And a PET scan that was done 3 months after the first one showed new hypermetabolic lesions affecting the adrenal glands, the pancreas, the bone, the lungs, which was very suspicious for a malignant process. And the previous vascular hypermetabolism that was seen was still present and even increased in some segments. In light of these findings, he underwent an adrenal cytopunction, showing poorly differentiated carcinoma of unknown origin. That shifted our diagnosis to a hypercoagulable state secondary to malignancy with an associated paraneoplastic vasculitis. The patient was treated with chemotherapy and then later switched to immunotherapy. And a PET scan that was done 8 months after showed significant improvement in his malignant involvement and complete resolution of the vascular hypermetabolism. So we're facing a very interesting case of paraneoplastic vasculitis, which represents only about 2 to 5% of all vasculititis and is most often associated with hematologic cancers rather than solid tumors. And although it can affect all types of vessels, the most frequently involved vessels are the small and medium-sized vessels. The diagnosis is based on correlation in time, with a typical cutoff of 12 months between the diagnosis as vasculitis and malignancy. And retrospective confirmation can be obtained when we see improvement in vasculitis signs after treating the underlying malignancy. So our case is a good reminder to adopt a a systematic approach to diagnosing unexplained arterial thrombosis. In the case of our patient, after our initial investigation, we weren't able to exclude vasculitis and malignancy. But we do want to point out that in the case of our patient, there was no indication for a specific malignancy screening, considering that he was younger and also that we had low clinical suspicion initially with our normal CT and PET findings. So we think that in the case of our patient, the delay in diagnosis was probably rather due to his atypical presentation, also considering that his vasculitis manifestations predated his signs of underlying malignancy. In conclusion, it is important to keep in mind paraneoplastic vasculitis. When we see cases of vasculitis with atypical clinical features and inadequate response to conventional vasculitis treatment, and also to keep in mind that up to 20% of paraneoplastic vasculitis can present before the first signs of malignancy, acting as a true vessel of warning. Thank you.
Thank you very much.
Would you mind to remind me what was the original neoplastic condition?
So we saw that on the biopsy, there was carcinoma that was poorly differentiated, but it wasn't clear what was the actual primary source of the carcinoma, because on immunochemistry tests, some stains pointed out towards a certain origin, but there were some discrepancies, so it wasn't possible in the end to identify the primary.
And what's happening to the patient now?
Yeah, so actually he was initially treated with empirical chemotherapy, paclitaxel and carboplatin, and then his cancer was found to have high PD-L1 expression, so he was treated with pembrolizumab. And 8 months after, we see that there are signs of improvement in his malignancy. So there was decreased malignant involvement in his repeat PET scan.
Medicine used to be simple.
Indeed.
Okay. Any questions?
Yeah, I have a question. Jim Ducatis from Canada, Internal Medicine. Very nice presentation. One comment first to preface is in a patient who has multiple infarcts diffusely. Another consideration, especially in the setting of malignancy, is non-bacterial or merantic endocarditis, which can be very difficult to diagnose. But my question is, what was really your rationale or the consultant's rationale for using an anticoagulant in this clinical setting?
I think initially when we didn't see that all the other outpatient investigations in a patient with just his age and multiple infarcts bilateral, it was very suspicious for an embolic process, and I think that's why they started him initially on anticoagulation. And afterwards, even though we couldn't find a clear cause, I think they just kept it just in case.
Well, my only point would be that we know in other sort of paradigms, for example, embolic stroke of undefined significance, it doesn't seem to, anticoagulants don't seem to be any better than antiplatelet drugs. And just a word of caution when you're using the anticoagulants in a condition, a patient where you're not sure what the underlying diagnosis is, there can be risks associated with it. So my suggestion to trainees is, if you administer an anticoagulant, just like with any other class of drugs, what are you treating? So just to keep that in mind.
Indeed. And when we think about the etiologies of arterial thrombosis, there are some that specifically, anticoagulation can even worsen, especially in atherosclerosis emboli, for example, it could loosen the plates, make them weaker. So in those cases, it's clear that antiplates would actually be better.
Luc Mouton from France. Congratulations. Since you have infarct, don't you think that it is large and medium-sized vessel vasculitis? And then we could, for instance, perform a temporal artery biopsy. You can have a positivity outside from giant cell arteritis, and you can identify other vasculitis. And last question, because of the cancer, did you measure the IgA level that can be increased in paraneoplastic vasculitis?
So for the infarcts, I think like in the case of our patient, it was afterwards clear that the cause of his infarcts wasn't actually the paraneoplastic vasculitis, but the hypercoagulable state secondary to his underlying malignancy. And we did have like very extensive vessel wall imaging that was done, but I didn't present it. So he did have like MR vessel wall imaging of the thoracic and abdominal level. They didn't see any signs of like smaller vessel vasculitis. And for the second question, I have a little blank. Could you remind me again?
IgA.
Oh, the IgAs. Yeah, so actually I think in his very extensive panel, they did measure the immunoglobulins. It wasn't for paraneoplastic vasculitis at the time because we didn't think about the diagnosis, but from what I remember, the IgA levels were normal.
Thank you. Last question, please.
Just Odekok, South Africa, just the significant weight loss initially, if I remember, in a young person again, would probably lean towards, and I think that goes to your question about the anticoagulants, that the weight loss for me would have been, yeah, I know the PET scan didn't help, but yeah, that would have been the sort of the direction. And just a question, why didn't you treat with steroids for a change?
Why didn't we treat the steroids? Why didn't we use steroids for this patient? He actually had steroids when we saw like the vasculitis signs. We treated him like initially with normal treatment for Takayasu, so he did have steroids. He didn't respond. We added like methotrexate. He didn't respond, and then he went on to receive infliximab.
Okay, thank you very much. We have to move on.